A child has trouble paying attention. He speaks slowly. He understands slowly. And he seems tired every single day. A parent may think, maybe this is a learning problem. A doctor may think, maybe this is developmental delay. And sometimes, the child may receive another label. Autism spectrum disorder. ASD. But here is the question. What if this child is not just inattentive? What if his eyes suddenly roll upward? What if his walking pattern keeps getting stranger? What if exercise makes his body twist? What if the symptoms are worse in the evening? What if he has chronic nasal congestion? And what if he had low muscle tone as a baby? Then the story may not be so simple. This may not be only developmental delay, and it may not be only autism. There may be something deeper underneath. An inborn error of metabolism. An IEM. Today's story is about a child whose attention problems, ASD record, and long-standing fatigue hid the real diagnosis for years. He was eventually diagnosed with AADC Deficiency. The name sounds rare, and for most people, it sounds unfamiliar. But the most frightening part is not just how rare it is that the clues were there from the beginning. Hidden in his language, hidden in his eyes, hidden in the way he walked, hidden in his fatigue, and hidden in small signs from the autonomic nervous system. The problem was that the clues were scattered, so they were easy to miss, until one day this boy walked past 200 meters, and suddenly his body seemed to flip a switch. He locked up. Only then did the real cause begin to surface. This is not an ordinary developmental story. Inside this child's body, there was a production line for making neurotransmitters. That production line helps make dopamine. It also helps make serotonin. And dopamine and serotonin affect movement, sleep, mood, blood pressure, the gut, and a child's development. When a key enzyme on that production line breaks down, many different symptoms can become connected. Chapter 1. After 200 meters, the boy's body suddenly locked up. This is a real case. A 15-year-old boy of Turkish origin. At first, he did not look like a typical child with a rare disease. He did not suddenly fall into a coma. He did not have severe seizures. His MRI did not immediately show a major problem. His EEG did not capture typical epileptic activity. His illness came quietly. It simply made him speak a little more slowly, understand a little more slowly, get tired more easily, and struggle to stay focused. These symptoms can easily be placed into a familiar category: developmental concerns, learning difficulties, autism spectrum disorder, or simply a child who is hard to explain. But later, the doctors realized that was not the whole story. Scene 1. At birth, everything looked too normal. When this boy was born, there was nothing obviously abnormal. He was the second child in the family. His parents were healthy. There was no consanguinity. He also had 2 healthy brothers, no difficult delivery, no suspicion of a genetic disease at birth, no long family history of similar problems. That kind of beginning can easily lower everyone's guard, because everything looks too normal. But that is exactly the point. A normal birth history and no family history do not completely rule out an inborn error of metabolism, especially when the condition is mild or has a later presentation, like some forms of AADC deficiency. At first, they may not look like a severe rare disease at all. Scene 2. The first warning sign. Appeared around age 6. The boy first came to medical attention at about 6 years old. The problems documented by his doctors were mild intellectual disability, language delay, fatigue, and difficulty concentrating. That combination is very common. Many people would first wonder, is this a neurodevelopmental condition? Is it a learning disorder? Is it attention deficit? Is it autism spectrum disorder? And what made it easier to overlook was that he had no unusual facial features. His physical exam was basically normal. There was no single symptom dramatic enough to make doctors immediately think of a rare disease. But looking back, these were early clues. The earliest signs in this case were not severe movement problems. They were cognitive difficulties, language delay, fatigue, and attention problems. And those can be very easy to underestimate. Scene 3. The ASD label appeared, but it was not the end of the story. Later, the case record included autism spectrum disorder, or ASD. Doctors saw autism spectrum-related features in this child. At the same time, they also saw mild intellectual disability, language delay, fatigue, and attention problems. But here is the key reminder. ASD can be a real label. Attention problems can be real symptoms, but they may not be the whole answer. If a child has ASD or attention problems, and standing right beside those symptoms are other clues: abnormal movements, abnormal eye movements, nasal congestion, low muscle tone, symptoms that worsen after exercise, then we cannot stop at a behavioural diagnosis alone. The view has to widen. Because there may be a neurometabolic disorder underneath. Scene 4. 1 year later. The body revealed. Harder evidence. About a year later, doctors noticed that his gait had changed. Both feet began to rotate inward. His elbows and wrists also showed flexion. This change mattered. It moved the story away from only development and behaviour and toward the motor system. A child with poor attention and slow language can have many possible explanations. But if the walking pattern begins to change, if the hands and feet develop abnormal postures, if body movements become increasingly unusual, then the diagnosis cannot stay only in the categories of psychology, education, or development. AADC deficiency often involves the motor system, and sometimes dystonia is the clue that helps solve the case. Scene 5. The eyes that suddenly looked upward. Later, the boy gradually developed a strange symptom. His eyes would move upward involuntarily, and during these episodes, he remained conscious. That detail is very important. When many parents see a child's eyes suddenly roll upward, their first thought is, could this be a seizure? Doctors naturally consider EEG testing, but in this child, the EEG was normal. The brain MRI was also normal. At that point, the symptom could not be explained only as epilepsy. In AADC deficiency, oculogeric crises can look very much like seizures, but they are not necessarily seizures. Upward eye deviation, preserved awareness, a normal EEG, a normal MRI. Put together, these are a warning. The doctor has to rethink the case. Scene 6. The most frustrating test result is often normal. During his evaluation around age 6, this boy had many tests: karyotype analysis, chromosomal microarray, testing related to Fragile X syndrome, testing related to myotonic dystrophy, and a gene panel containing 150 genes. That panel focused mainly on genes related to epilepsy with or without intellectual disability. And what did the results show? No pathogenic variants were found. For the family, this can be deeply frustrating, because the child is clearly not well. But report after report comes back as if to say, we did not find the problem. But one sentence is essential. A negative genetic test does not mean a child has no genetic disorder. The key question is, which genes were actually tested? And was the truly relevant gene included in the test? Scene 7. The missed suspect was the DDC gene. Later, it became clear that the original gene panel did not include the DDC gene, and DDC is the core gene involved in AADC deficiency. In other words, the earlier testing looked at many genes, but the most important suspect was never questioned, so the negative result was not surprising. If the DDC gene is not tested, AADC deficiency can be missed. That is one reason a child can clearly have symptoms, yet early testing still fails to find the answer. Scene 8. At age 12, the diagnosis suddenly became clearer. By age 12, the boy's gait abnormality had worsened. More importantly, doctors noticed a very specific trigger. If he walked more than 200 meters or did other types of exercise, his symptoms could be triggered. During an episode, his head would extend and twist. His right arm and right foot would become especially tense. It was as if his body suddenly lost control. But remarkably, if he stopped and rested, the abnormal movements could slowly reverse. That pattern was very important. Exercise-induced, reversible with rest, a dystonic crisis. In this mild case, it was one of the most striking abnormal findings. Scene 9. The 200-meter mark was like an invisible switch. This child's problem was not ordinary tiredness. He was not refusing to walk. He was not lazy. And this was not a psychological problem. His body truly could not sustain it. After walking more than 200 meters, his motor control system began to fail. It was as if his body was controlled by an invisible switch. Before that point, he could keep going. After that point, he suddenly locked up. His fatigue was not only after exercise, it was present almost throughout the day. Persistent fatigue, combined with exercise-induced body twisting, suggested that the problem might not be muscle strength itself. It might be in the chemical signals the brain uses to control movement. In other words, the neurotransmitter system. Scene 10. The symptoms were worse in the evening. His dystonic crises were more common in the evening. That time pattern alone cannot diagnose AADC deficiency. But it is worth noticing. Fatigue throughout the day, symptoms triggered by exercise, more episodes in the evening. This suggests the body was not dealing with a fixed structural injury. It looked more like a dynamic regulation system was failing. Fatigue, physical effort, time of day. These factors stacked together and made the symptoms more obvious. Scene 11. Looking back, the early clues suddenly connected. After the diagnosis, doctors reviewed his history again. That was when they realised the clues had been present very early. During the neonatal period, he had nasal congestion. At 4 months old, he had upward gaze. Over time, these upward-looking episodes increased in duration and frequency. At 9 months old, he still could not sit. That suggested possible low muscle tone, but by themselves, none of these clues looked alarming enough. Nasal congestion could look like an ear, nose, and throat problem. Upward eye movements could look like seizures or an eye problem. Not sitting at 9 months could look like ordinary developmental delay. But once these clues were placed together, the picture changed completely. The clues in AADC deficiency do not always appear in one place. They can be scattered across different body systems. The autonomic nervous system, eye movements, muscle tone, developmental milestones. Each clue is like a fragment. Only when you put them together does the answer begin to appear. Scene 12. The test that solved the case was not MRI or EEG. In this case, the MRI did not provide the answer. The EEG did not provide the answer. What finally changed the direction was whole exome sequencing. Doctors performed Trio WES. That means whole exome sequencing was done for the child and both parents. The result showed a homozygous variant in the child's DDC gene. Several prediction tools suggested that this variant might be pathogenic. That step was critical. When routine tests are negative and an earlier gene panel is also negative, whole exome sequencing may uncover an inherited metabolic disorder that was missed before. Scene 13. The gene was the suspect, but enzyme activity delivered the verdict. But finding a new gene variant was not enough by itself. The doctors needed functional evidence, so they tested plasma AADC enzyme activity. The result showed that this child's AADC activity was very low. At that point, the diagnosis was finally confirmed. The cause was AADC deficiency, a DDC gene variant, together with markedly reduced AADC enzyme activity. Eventually, he was diagnosed at age 13. Scene 14. The disease name connected. All the scattered symptoms. Now looking back, his symptoms were not really scattered. Attention problems, fatigue, language delay, abnormal walking, upward eye movements, nasal congestion. They looked like separate problems, but they could all be connected by one underlying cause, a disorder of monoamine neurotransmitter synthesis. Put more simply, a key step in making dopamine and serotonin was not working properly. So movement could be affected, sleep could be affected, mood and behaviour could become unstable, the autonomic nervous system could be involved. Development could be slowed. So why did he not look like a typical severe case of AADC deficiency? Because most typical patients develop obvious symptoms within the first few months of life. Symptoms like low muscle tone, oculogyric crises, movement disorders, developmental delay, and autonomic dysfunction. But this boy had a mild and atypical presentation. He first came to medical attention after age 6 because of mild intellectual disability, language delay, fatigue, and attention problems. Only later did he gradually develop exercise-induced dystonic crises. That is why he was easier to mistake for a child with developmental issues, attention problems, or autism spectrum disorder. Scene 15. Treatment did not make the story miraculous, but it changed the direction. After the diagnosis, doctors first started pyridoxine, a form of vitamin B6 treatment. Later, they added pramipexole. After treatment, his exercise intolerance improved. His dystonic crises also decreased. This was not a story of overnight recovery, but it shows something important. Even when mild AADC deficiency is diagnosed relatively late, finding the right direction and starting appropriate treatment may still improve quality of life. End of Chapter 1. Do not let one label hide the real cause. The most important thing to remember from this case is not just the name AADC deficiency, it is the diagnostic sequence. At first, the child looked like he had mild intellectual disability, language delay, attention problems, and ASD. Later, he developed gait abnormalities and upward eye movements. The EEG was normal. The MRI was normal. The early gene panel was negative. Then, at age 12, exercise-induced symptoms appeared. After walking more than 200 meters, his body began to twist. Rest helped the symptoms ease. They were worse in the evening. Finally, whole exome sequencing found a DDC gene variant. And AADC enzyme activity testing confirmed the diagnosis. That is the core of this case. A mild case of AADC deficiency may not look typical at first. It may require doctors and families to connect the developmental clues, behavioral clues, movement clues, eye movement clues, and autonomic clues one by one. ASD, language delay, attention problems, and mild intellectual disability can all be real labels. But they may not explain everything. If a child has those symptoms and also has upward eye movements, body twisting after exercise, persistent fatigue, chronic nasal congestion, delayed sitting, and low muscle tone, especially if MRI and EEG do not explain it, then the next question should be asked. Could this be a neurotransmitter synthesis disorder? Could this be an inborn error of metabolism? Could this be AADC deficiency? After the 200-meter mark, this child's body finally spoke the diagnosis. That 200 meters was not just a distance, it was a line. Before that line, the child could still barely keep going. After that line, his motor system could no longer hold, because inside his body, the key enzyme needed to make dopamine and serotonin was not working properly. So this case reminds us, when a child's symptoms cannot be fully explained by one label, do not stop asking questions too soon. Sometimes, the real answer is hidden in the small clues that seem scattered at first. Chapter 2. Where exactly does AADC deficiency get stuck? In Chapter 1, we talked about the boy whose body suddenly locked up after he walked past 200 meters. So now comes the question, why would a child have poor attention, delayed speech, constant fatigue, upward eye movements, and abnormal twisting when he walks? The answer is hidden inside a chemical production line in the body. This condition is called AADC deficiency. Its full name is aromatic L-amino acid decarboxylase deficiency. In simple terms, there is a key enzyme in the body called AADC. This enzyme helps the body make two very important chemical messengers. One is dopamine, the other is serotonin. Dopamine helps with movement, starting movements, and controlling posture. Serotonin helps regulate sleep, mood, gut function, and behavioral stability. When the AADC enzyme does not work well, the body cannot make enough dopamine or enough serotonin, and when that happens, the entire system downstream can begin to malfunction. AADC deficiency is an autosomal recessive genetic disorder. That usually means a child has to inherit one affected gene from each parent in order to develop the condition. It is also an inborn error of metabolism, or IEM. More specifically, it is a disorder of monoamine neurotransmitter synthesis. The disease-causing gene is called DDC. The DDC gene provides the instructions for making the AADC enzyme, and AADC needs a helper in order to work. That helper is the active form of vitamin B6. It is called PLP, or pyridoxal phosphate, but this point is very important. AADC deficiency is usually not the same thing as a regular vitamin B6 deficiency. It does not mean a child can simply take more vitamin B6 and be cured. The real problem is that the DDC gene has variants that cause AADC enzyme activity to drop significantly. So the goal of vitamin B6 treatment is not to repair the gene. The goal is to help whatever AADC enzyme activity remains work a little better. Think of it like a damaged machine. You cannot turn a broken machine into a brand new one just by adding oil. But if the machine still has a little function left, the right support may help it turn a little more. AADC deficiency mainly affects movement, behavior, and cognitive development. It is not a typical neurodegenerative disease. It is not the kind of condition where the brain simply keeps deteriorating rapidly over time. But the symptoms can fluctuate. Oculogyric cries, dystonia, and sudden body twisting may change with age, fatigue, infection, and stress. In typical AADC deficiency, symptoms often begin within the first 6 months of life. A baby may have feeding difficulties. The body may feel very floppy. The eyes may roll upward. Sleep may be disrupted. Development may fall behind. Body posture may become abnormal. And the autonomic nervous system may be affected. In severe cases, many children cannot sit, stand, or walk. But mild cases can look different. Some children can still walk independently. They may retain some motor milestones, but they can still have oculogyric crises, easy fatigue, language and cognitive difficulties, diarrhea, low blood sugar, or chronic nasal congestion. In some mild children, early movement problems may not be obvious. That is one reason they may be mistaken for children who are simply developmentally delayed, inattentive, or on the autism spectrum. So what are the two pathways that AADC is involved in? We can imagine the body as a factory. Inside this factory, there are two major production lines. One line helps make dopamine, the other helps make serotonin. AADC gets stuck at the key final step of both lines. The first line, the dopamine pathway. The body can first use phenylalanine to make tyrosine. Tyrosine then goes through several steps and becomes L-dopa. Then, ADC steps in. AADC helps convert L-dopa into dopamine. So, in this pathway, the step that gets blocked is L-dopa becoming dopamine. After dopamine is made, it can be converted into norepinephrine. and in certain tissues, norepinephrine can be converted into epinephrine. So if the AADC step is impaired, dopamine is not the only thing that becomes low. Norepinephrine can also become low. Epinephrine can also be affected. This helps explain why AADC deficiency is not only a movement disorder. It can also affect blood pressure, heart rate, body temperature, sweating, and blood sugar. The second line, the serotonin pathway. The second pathway is the serotonin pathway. The body starts with tryptophan as the raw material. Tryptophan is processed into 5-HTP. Then AADC steps in again. AADC helps convert 5-HTP into serotonin. So in this pathway, the step that gets blocked is 5-HTP becoming serotonin. After serotonin is used, the body breaks it down into a metabolite called 5-HIAA. Remember this simple idea. When serotonin is low, its breakdown product is usually low as well. So the core problem in AADC deficiency is not that tyrosine cannot become dopamine at all, and it is not that tryptophan cannot become serotonin at all. More accurately, the final key step is blocked. L-dopa cannot be efficiently converted into dopamine, and 5-HTP cannot be efficiently converted into serotonin. AADC is like the last machine on the production line. The raw materials arrive, but the final machine does not turn properly. So the materials pile up in front of the machine, and the products after that step are not made in enough amounts. Dopamine becomes insufficient. Serotonin becomes insufficient. Norepinephrine becomes insufficient. And epinephrine can also be affected. That is why AADC deficiency can affect so many different systems. It does not affect only one organ. It affects an entire network of chemical signals in the nervous system. Chapter 3. What happens inside the body when AADC is blocked? Let's stay with the factory image. Under normal conditions, raw materials enter the production line. Each machine performs its step, and eventually the final product is made. But in AADC deficiency, one of the key final machines is broken. So a typical pattern appears. The substances before the blocked step build up. The substances after the blocked step go down. In cerebrospinal fluid testing, doctors can see this as a kind of metabolic fingerprint. Cerebrospinal fluid, or CSF, is the fluid that is closer to the environment around the brain. The neurotransmitter metabolites inside that fluid can help doctors understand where the chemical pathway is blocked. When AADC is not working normally, L-dopa cannot smoothly become dopamine, and 5-HTP cannot smoothly become serotonin. So the precursors go up, the products go down. L-dopa goes up, 5-HTP goes up, 3-OMD goes up. These are substances building up before the blocked step. Meanwhile, downstream metabolites related to dopamine, serotonin, and norepinephrine go down. Epinephrine can also be affected. One name is especially important here: 3-OMD. When too much L-dopa builds up, the body diverts some of it into another pathway. That pathway produces 3-OMD. So when 3-OMD is elevated, it is like a message to the doctor. L-dopa is piling up, but dopamine is not being made properly. This process may also involve folate metabolism inside the brain. That is why, in some patients with AADC deficiency, clinicians may discuss low 5-MTHF and the use of folinic acid. When AADC is blocked, the problem is not only low dopamine and low serotonin. The substances piling up before the block may also affect other metabolic routes. The typical CSF profile in AADC deficiency can be remembered in one simple phrase. Precursors are high, breakdown products are low, and pitaranes are usually normal. L-dopa is high, 5-HTP is high, 3-OMD is high. These are the substances building up before the block, but 5-HIAA is low, HVA is low, MHPG is low. These are breakdown products of downstream neurotransmitters. When they are low, it suggests that the body is not making enough serotonin, dopamine, and norepinephrine. There is another group of substances called pterins. These include neopterin, dihydrobiopterin, and tetrahydrobiopterin. In AADC deficiency, they are usually normal. That matters because it helps doctors distinguish AADC deficiency from BH for metabolism disorders. It also helps separate AADC deficiency from other monoamine neurotransmitter disorders. This is the metabolic fingerprint of the disease. It is not just a guess. It is not just about whether a child looks like the condition. It is about chemical evidence left behind by the body. The diagnosis of AADC deficiency depends on three core diagnostic keys from genetic and metabolic testing. The first key is the CSF neurotransmitter profile. The second key is finding biallelic pathogenic variants in the DDC gene. The third key is low AADC enzyme activity in plasma. Together, these three keys can help confirm the diagnosis. So AADC deficiency cannot be diagnosed by symptoms alone. It requires genetic and metabolic evaluation. It needs genetic evidence, and it also needs functional evidence. Chapter 4. Why are monoamine neurotransmitters so important? AADC deficiency can look confusing. Some children may look like they have cerebral palsy. Some may look like they have epilepsy. Some may look like they are on the autism spectrum. Some may look like they have ADHD. And some may seem to have only developmental delay. So why can one condition look like so many different things? Because AADC deficiency does not affect just one single point. It affects an entire signaling system. That system is called the monoamine neurotransmitter system. It includes dopamine, serotonin, norepinephrine, and epinephrine. When these signals are disrupted, movement, sleep, mood, gut function, the autonomic nervous system, and development can all be affected. First, low dopamine. The motor system loses fine control. Let's start with dopamine. Dopamine is closely connected to motor control, especially in a part of the brain called the basal ganglia. You can think of the basal ganglia as the brain's movement control center. It helps start movements, it helps stop movements, and it helps adjust the force, rhythm, and timing of movement. When dopamine is too low, this movement control center can become unstable. A child may have low muscle tone, reduced movement, difficulty initiating movement, abnormal walking, twisted postures, dystonia, and oculogeric crises. An oculogeric crisis means the eyes drift upward, or sometimes to the side, and stay there, or keep returning there. Sometimes it can also come with abnormal postures of the face, the trunk, or the arms and legs. These episodes may last for a few minutes, or they may last for hours. They often appear after fatigue. They may become more obvious in the evening. They can happen more easily during infections, and stress may make them worse. In many cases, the child remains awake and aware. That is why these episodes can easily be mistaken for seizures. But in AADC deficiency, the real problem may not be abnormal electrical firing from the cerebral cortex. It may be a disorder of neurotransmitter synthesis. In other words, the issue may not be an electrical storm. It may be a shortage of chemical signals. True epilepsy is not very common in AADC deficiency. It has been reported in fewer than about 5% of cases. So if a child's eyes roll upward, but the EEG is normal, and the child also has fatigue, movement problems, and autonomic symptoms, then doctors need to think deeper. That is one reason AADC deficiency may first be mistaken for cerebral palsy, epilepsy, or another movement disorder. Second, low serotonin. Sleep, mood, gut function, and behavior can all be affected. Now let's talk about serotonin. When many people hear serotonin, they think only about mood. But serotonin does much more than that. It also helps regulate sleep rhythm, gut movement, pain processing, and behavioral stability. So children with AADC deficiency may have sleep problems. Some may have insomnia. Some may be unusually sleepy. They may be irritable. They may become upset easily. They may seem anxious. Some may show autism-like features, attention problems, or behavioral difficulties. The gastrointestinal system can also be affected. A child may have gastroesophageal reflux, vomiting, diarrhea, constipation, or feeding difficulties. When you look at each symptom alone, none of them screams rare disease. Poor sleep can look like a sleep problem. Irritability can look like a behavioral problem. Gut symptoms can look like a digestive problem. Poor attention can look like ADHD. Social and language differences can look like ASD. But when these symptoms appear together with oculogeric crises, abnormal movements, low muscle tone, and chronic nasal congestion, we should not look only at the surface. There is another important pattern. Dystonia in AADC deficiency can sometimes fluctuate throughout the day. It may worsen in the evening and improve after sleep. This pattern, symptoms building through the day and worsening later, is important in many neurotransmitter disorders. So AADC deficiency is not only a movement disorder. A child's sleep, mood, behavior, and gut symptoms may all be clues on the same line of evidence. Third, low norepinephrine and epinephrine. The autonomic nervous system can also become unstable. Norepinephrine and epinephrine can be understood as part of the body's emergency regulation system. They help regulate blood pressure, heart rate, sweating, body temperature, blood sugar, and the response to stress. So when this pathway is affected, a child may develop autonomic symptoms. These can include chronic nasal congestion, drooping eyelids, small pupils, abnormal sweating, poor temperature regulation, low blood pressure, low blood sugar, slow heart rate, drooling, worsening during infections, abnormal gut motility, and upper airway problems. These signs may look scattered. One here, one there, but many of them may be related to the autonomic nervous system. And the autonomic nervous system is influenced by monoamine neurotransmitters. Variants in the DDC gene can reduce AADC enzyme activity. When AADC activity goes down, dopamine and serotonin levels go down. And when dopamine is low, norepinephrine and epinephrine can also be affected. So the central nervous system is affected. The peripheral autonomic nervous system is affected too. In the end, a child may show developmental delay, intellectual and language difficulties, abnormal movements, oculogeric crisis, and autonomic dysfunction. Why is AADC deficiency so easy to misunderstand? Because it does not behave like one single disease. It does not look like ordinary epilepsy, where the main issue is seizures. It does not look like ordinary cerebral palsy, where the main issue is abnormal posture and motor function. And it does not look like isolated ASD or ADHD, where the main concerns are usually social communication, language, or attention. So what does AADC deficiency look like? It looks more like a child's signaling system is failing in several places at once. The movement signal is weak. Motor control becomes unstable. Sleep signals become disrupted. Mood and behavior may fluctuate. Autonomic regulation becomes unstable. Blood pressure, sweating, body temperature, blood sugar, and gut function may all be affected. Development can slowly fall behind. That is what makes this condition so confusing. It can disguise itself. It can look like developmental delay. It can look like autism spectrum disorder. It can look like attention problems. It can look like cerebral palsy. It can look like epilepsy. It can look like ordinary fatigue. But the root cause may be in the same place. The key AADC machine is not working. The body cannot make enough dopamine. It cannot make enough serotonin. Norepinephrine and epinephrine are affected as well. The raw materials build up. The downstream signals are not enough. That is why one child can have so many symptoms that seem unrelated. But they are not random. If you draw the metabolic pathway, you can see that all these clues point back to the same place. The AADC step is blocked. Chapter 5. What role does MAO play here? Earlier, we said that AADC is involved in production. So what does MAO do? In one sentence, AADC helps make the signal. MAO helps clear it away. Dopamine and serotonin cannot stay in the system forever after they are used. If they are never cleared, the signals can also become disordered. So the body needs enzymes to break down these neurotransmitters. One important group of enzymes is called MAO. MAO stands for monoamine oxidase. That sounds technical, but you can think of it as a cleanup crew for neurotransmitters. AADC helps produce the goods. MAO helps break down what has already been used. There are two main types of MAO. One is MAOA, the other is MAOB. In simple terms, MAOA more often processes serotonin, norepinephrine, and epinephrine. It can also process dopamine. MAOB more often processes dopamine and related molecules, But these two enzymes are not completely separate. They have different preferences, but their roles overlap. Dopamine can be handled by both. This helps explain why MAO inhibitors are sometimes used in the treatment of AADC deficiency. The problem in AADC deficiency is not that the child has too many neurotransmitters. The problem is that the body makes too little. The small amount of dopamine and serotonin that the child can make may be broken down quickly by MAO. If that happens, even less is available for the body to use. So the goal of an MAO inhibitor is not to fix the AADC enzyme. It is to prevent the small amount of dopamine and serotonin that has already been made from being cleared away too quickly. To let those signals stay around a little longer and work a little longer. Think of it this way. The production line is already making too little. This is not a warehouse with too much inventory. MAO inhibitors do not repair the machine. They are more like telling the cleanup crew, do not clear away this small amount too quickly. Let the body use it a little longer. Chapter 6. How is AADC deficiency diagnosed? One of the hardest things about AADC deficiency is that the main problem is in the neurotransmitter system, especially the neurotransmitter system inside the brain. Blood and urine tests can sometimes give clues, but sometimes they can also be misleading. To diagnose this condition, doctors cannot rely only on whether a child looks like the disease, and they cannot rely on one single test. First, doctors have to recognize the clinical clues: a floppy body, developmental delay, upward eye movements, body twisting after exercise, long-standing fatigue, sleep problems, nasal congestion, low blood sugar, attention and behavioral concerns. Then, genetic and metabolic testing becomes important. There are three main categories of core testing. First, CSF neurotransmitter metabolites. Second, DDC gene testing. Third, plasma AADC enzyme activity. These three types of testing are like three keys. If at least two of those keys fit, the diagnosis becomes very strong. In some situations, finding biallelic pathogenic variants in the DDC gene can establish the diagnosis, or if the CSF profile fits and AADC enzyme activity is clearly low, that can also confirm the diagnosis. The first key, the metabolic fingerprint in CSF AADC deficiency, can leave a very typical metabolic fingerprint in the cerebrospinal fluid, or CSF. You can remember it this way: the raw materials before the block go up, the products after the block go down. Because the production line is stuck, L-dopa goes up, 5-HTP goes up, 3-OMD goes up. These are the substances stuck before the blocked step. But 5-HIAA goes down, HVA goes down, MHPG goes down. These are the breakdown products of downstream neurotransmitters. When those breakdown products are low, it suggests that the body is not making enough serotonin, dopamine, and norepinephrine. There is also a group of tests called pterins. These include neopterin, dihydrobiopterin, and tetrahydrobiopterin. In AADC deficiency, these are usually normal. That helps doctors separate AADC deficiency from BH4-related disorders. But mild patients can sometimes be less typical. For example, CSF-HVA or 5-HI-A may occasionally be normal, so doctors should not rule out AADC deficiency based on only one marker. The second key: plasma, AADC enzyme. Activity. If enzyme activity is clearly low, it means the AADC machine is truly not turning properly. This is functional evidence. It is not only about what a genetic report says, it is about directly testing whether the enzyme can still do its job. The third key: DDC gene testing. If testing finds biallelic pathogenic or likely pathogenic variants in the DDC gene, that strongly supports AADC deficiency. But if the report says VUS, a variant of uncertain significance, that is not enough to make the diagnosis by itself. It has to be interpreted together with the CSF neurotransmitter profile, enzyme activity, and the child's clinical picture. Diagnosis cannot depend only on a genetic report. This point is very important. Genetic testing is important, but it is not perfect. Some routine tests may miss deep intronic variants. They may miss promoter region problems. They may also miss deletions or duplications. Some children may have very typical symptoms. Their CSF profile may fit. Their plasma AADC enzyme activity may be clearly low, but the genetic report may find only one variant.
Or at first, it may not find a clear variant at all. So we cannot simply say, if the genetic test is negative, then this is not AADC deficiency. A more reliable approach is to look at the whole picture. Look at the clinical presentation. Look at the CSF neurotransmitter profile. Look at plasma AADC enzyme activity. Then look at the DDC gene result. All of these pieces have to be interpreted together. Why MRI and EEG often do not give the answer. Many parents ask, if my child's eyes roll upward or the body has episodes, can an MRI show the problem? Can an EEG detect it? The issue is that brain MRI in AADC deficiency is often normal, or it may show only non-specific changes. The EEG may also be normal in many cases. That is one reason this condition is so easy to misunderstand. When parents see a child's eyes roll upward, they often think of seizures. Doctors may also order an EEG. But if the EEG is normal and the MRI is normal, that does not mean the child has no problem. MRI and EEG are often used to help distinguish between an epileptic seizure and an oculogyric crisis. If the child remains aware, the EEG is normal, and there are also fatigue, movement problems, and autonomic symptoms, then doctors should keep thinking about neurotransmitter disorders. Blood and urine clues can help, but they are not enough. Some blood markers can support suspicion. For example, low whole blood serotonin or elevated prolactin. But these cannot diagnose AADC deficiency by themselves. There is also a urine marker called VLA. VLA stands for vanillactic acid. In AADC deficiency, VLA may be elevated. If urinary VLA is elevated, doctors should consider this condition. But the increase can be subtle. It can be easy to miss. More importantly, a normal urine test does not rule out AADC deficiency. Why? Because the kidneys have high AADC activity. Even when a person
has AADC deficiency throughout the body, the kidneys may still produce some dopamine and related metabolites locally. So dopamine, HVA, and VMA in the urine may be normal, they may be low, or they may be high. They do not always reflect what is happening in the brain. So urine clues can sometimes lie. The clues in CSF are closer to the scene of the case.
Chapter 7. How is AADC deficiency treated? Treatment for AADC deficiency can be understood in several different ways. First, doctors try to help the remaining AADC enzyme work a little better. Second, they may try to bypass part of the dopamine shortage by directly stimulating dopamine receptors. Third, they may try to slow down the breakdown of neurotransmitters. Fourth, they treat complications, sleep problems, gut problems, low blood sugar, oculogeric crises, movement problems, and autonomic symptoms. And fifth, there is gene therapy. Common first-line treatment approaches often include vitamin B6 or PLP, dopamine receptor agonists, and MAO inhibitors. But every child is different. Treatment has to be planned by a medical specialist. Families should never try these medications on their own. One vitamin B6 or PLP helping the remaining enzyme work a little better. The AADC enzyme needs PLP to function. PLP is the active form of vitamin B6. So doctors may try vitamin B6 supplementation, or in some cases, PLP itself. The goal is not to repair the gene. The goal is to help the remaining AADC enzyme activity work as well as it can. Pyridoxine, a common form of vitamin B6, is often considered first because it is widely available and relatively low cost. If a child cannot tolerate it, PLP may be considered instead. But not every patient has a clear response, and long-term high-dose vitamin B6 can also cause neurologic side effects, so the dose has to be controlled, and the child has to be monitored. 2 dopamine receptor agonists. Bypassing part of the dopamine shortage. If a child cannot make enough dopamine, can doctors stimulate the dopamine receptors directly? That is the idea behind dopamine receptor agonists. The factory cannot make enough dopamine, so the medication tries to ring the doorbell of the dopamine receptor. That way, the downstream system may still receive part of the signal. In clinical practice, non-ergot dopamine agonists are usually preferred. Examples include pramipexole, ropinirole, and rotigotine. These medications are usually started at a low dose. Then the dose is increased slowly, because they can also cause side effects. Movement problems, vomiting, sleep problems, and behavioral changes. Some ergot-derived medications, such as pergolide and cabergoline, are usually avoided because of the risk of fibrosis and heart valve disease. Bromocriptine also requires attention to cardiac screening. So these are not supplements. They are not simple wellness products. They need to be evaluated and prescribed by a physician. 3-MAO inhibitors, helping small amounts of neurotransmitters. Last longer AADC helps with production. MAO helps with breakdown. In AADC deficiency, the body already has too little of these neurotransmitters, so the purpose of an MAO inhibitor
is to keep the limited dopamine and serotonin signals from being broken down too quickly. It helps them stay around a little longer. But these medications also require caution, especially when they are combined with other drugs that can raise monoamine neurotransmitter levels. There can be risks, so MAO inhibitors must be used under medical supervision. 4. Folinic acid addressing possible brain folate issues. When the AADC step is blocked, L-dopa can build up. Some of that L-dopa may be diverted toward the 3-OMD pathway. This process may involve the use of methyl donors. In some patients, 5-MTHF levels in the cerebrospinal fluid may become low. That is why clinicians may sometimes discuss folinic acid, also known as leucovorin, but whether folinic acid should be used routinely still needs more research. If a child's condition worsens, or if doctors suspect a secondary brain folate problem, then folinic acid may be considered. 5-levodopa. Most patients do not respond well. When people hear that dopamine is low, they often think of levodopa. But in AADC deficiency, it is not that simple, because the blocked step is exactly this: L-dopa becoming dopamine. So most patients with AADC deficiency do not respond well to levodopa. There is another important caution. Combination products that contain carbidopa are usually avoided. Carbidopa inhibits AADC, and that may further affect an enzyme that is already not working well. Only a small number of patients with specific DDC gene variants may respond to levodopa without carbidopa. These are special cases. Families should not try this on their own. 6. Symptomatic treatment. Because the symptoms are scattered, treatment often has to be combined. AADC deficiency is not a one-point problem, so treatment is usually not one single medication. It often takes a combination approach. If a child has feeding difficulties, feeding therapy may be needed. In more severe cases, a gastrostomy tube or jejunal feeding may be considered. If the child has oculogeric crises or movement disorders, doctors may consider anticholinergic medications or treatments that help with sleep. If sleep is a major problem, melatonin or clonidine may be used in some cases. At the same time, doctors also have to manage gut problems, obstructive sleep apnea, low blood sugar, and autonomic symptoms. The treatment strategy can be understood through the mechanism, but in real life, the response often has to be watched over time, one medication at a time, one adjustment at a time. 7. Genetic counselling. Why it matters for the whole family. AADC deficiency is an autosomal recessive genetic disorder. If the family's specific variants are known, carrier testing may be possible, prenatal diagnosis may be possible, and some families may consider PGT, or pre-implantation genetic testing. If both parents are carriers, the risk for each pregnancy is roughly a 25% chance that the child will be affected, a 50% chance that the child will be a carrier, and a 25% chance that the child will be neither affected nor a carrier. That is why genetic counselling is so important for family planning. 8 medications and situations that need special caution. Patients with AADC deficiency need to be careful with certain medications. For example, central dopamine receptor antagonists. One example is metoclopramide, also known as Reglan. Some antipsychotic medications may also need caution. These drugs can worsen symptoms and may need to be avoided or used very carefully. 5-HTP should not be used as a treatment for AADC deficiency. There is no clear proven benefit and side effects are possible. SSR is also have limited evidence in AADC deficiency. They may worsen oculogeric crises, low muscle tone, or dystonia, so they are not recommended as routine treatment. There is another important risk area: infection, surgery, anesthesia. In these situations, patients with AADC deficiency may face autonomic and cardiopulmonary risks. So before surgery, during infection, or before anesthesia, cardiac evaluation may be needed, and an emergency plan should be in place. 9 gene therapy. Delivering the DDC gene to targeted brain areas. Today, AADC deficiency has entered the era of gene therapy. In the United States, Kebilidi, with the generic name L-amino exuparvovec 10-ec, has been approved for adults and children with AADC deficiency. It is an AAV vector-based gene therapy. In simple terms, a viral vector is used to deliver a working DDC gene to targeted areas of the brain. This is not a regular IV infusion. It is delivered through a single stereotactic neurosurgical procedure, with the therapy infused into the putamen. The putamen is involved in the brain's motor circuits. The main goal is to improve dopamine production, especially for motor function. But this is not germline editing. It does not change the genes in every cell of the body. And it does not mean that all neurotransmitters throughout the body are fully restored. Improvement in the serotonin system or in peripheral autonomic symptoms cannot simply be assumed. The FDA approval is an accelerated approval. The evidence is mainly based on early improvement in gross motor function at 48 weeks after treatment. Continued approval may depend on confirmation of clinical benefit. Common adverse reactions can include dyskinesia, fever, low blood pressure, anemia, drooling, insomnia, electrolyte abnormalities, and complications related to surgery. If a child's skull is not mature enough, or if neuroimaging shows that the procedure is not appropriate, the therapy may not be an option. This treatment also requires a center with expertise in pediatric stereotactic neurosurgery. In Europe, there is a related product called Upstaza. The EMA authorized it for patients 18 months and older with severe AADC deficiency, confirmed clinically, molecularly, and genetically. According to the EMA, the main study included 28 children with severe disease. They were between 1.5 and 8.5 years old. After 2 years, about 70% of the children gained head control, and about 65% were able to sit independently. The most common side effect was dyskinesia, or involuntary movement. Video. Ending. This is not just developmental delay. Inside every person's body, there is a production line for making neurotransmitters. The phenylalanine to tyrosine pathway feeds into dopamine production. The tryptophan pathway feeds into serotonin production. Dopamine also affects norepinephrine and epinephrine. These chemical signals help regulate movement, sleep, mood, blood pressure, body temperature, sweating, blood sugar, and gut function. And the AADC enzyme is one of the key machines on this production line. It needs PLP, the active form of vitamin B6, to work. But when DDC gene variants reduce AADC enzyme activity, the production line gets stuck at the final step. L-DOPA builds up but cannot become enough dopamine. 5-HTP builds up but cannot become enough serotonin. When dopamine is low, norepinephrine and epinephrine can also be affected. So a child may have a floppy body, upward eye movements, slow movement, twisted walking, poor sleep, excessive sweating, chronic nasal congestion, low blood pressure, and low blood sugar. The child may also have delayed speech, attention problems, autism-like features, or episodes that look like seizures. But what doctors are really looking for is not one single symptom. They are looking for a metabolic fingerprint. The precursors go up. L-DOPA is high, 5-HTP is high, 3-OMD is high. The downstream products go down. 5-HIAA is low, HVA is low, MHPG is low. The genetic evidence is biallelic pathogenic variants in the DDC gene. The functional evidence is low plasma, AADC enzyme activity. These are the core diagnostic clues for AADC deficiency. This is not simply a child being developmentally delayed. It is a neurotransmitter production line blocked at a critical step. When that key step is blocked, the precursors build up, and the products downstream are not made in enough amounts. The symptoms can look like threads scattered across the floor. Speech delay is one thread. Movement problems are another. Upward eye movements are another. Nasal congestion and low blood sugar are another. Attention and behavior problems are another. But once you draw the metabolic pathway, you can see where all those threads lead back. They lead back to the AADC step. So when a child has been labelled with cerebral palsy, epilepsy, sleep problems, developmental delay, ASD, or attention problems, but the symptoms do not fully fit, we should not stop asking questions too early. Sometimes the real cause is not that the child is not trying. It is not that the parents are overthinking, and it is not something one label can fully explain. Sometimes the real cause is a chemical production line in the body stuck at one critical step. This video is for medical education only. It is not personal medical advice, and it is not a diagnosis. The diagnosis of AADC deficiency requires specialized genetic and metabolic testing. Families should not self-diagnose based only on cerebral palsy, sleep problems, upward eye movements, or similar symptoms. Treatments such as vitamin B6, dopamine receptor agonists, and MAO inhibitors must be evaluated by medical specialists. Doctors have to consider the child's age, nutritional status, symptom severity, and genetic findings. Do not try these medications without medical supervision. If you are interested in inborn errors of metabolism, or IEMs, and in the connection between neurologic or psychiatric symptoms and inherited metabolic encephalopathies, you can find the full written version in the Shunyi series.